Looks like it only records 30 minutes at a time. That's going to be annoying. So those are our valves, our 4 valves, the 2 atrioventricular and the 2 semilunar. Here you see where they are. These 2 larger ones here are the AV valves. There's the left atrioventricular and the right atrioventricular, pulmonary semilunar, and aortic semilunar. And we will get a chance to see those when we dissect the heart in lab. That obviously is a drawing. Here's what it looks like in real life. We won't be doing this exact cut, but we will find ways to identify those valves. When it comes to valves, there are certain disorders that we can talk about. In the valves, they can sort of go bad in one of 2 different ways, more or less. So we talk about an incompetent valve and a stenotic valve, valvular stenosis. Incompetent valve. What does that word incompetent mean? Not working, right? We use that word to describe people sometimes. If you say they're incompetent, that means they are bad at whatever job you're talking about. So what is the job of a valve? Prevent backflow. So if it's incompetent, it's not doing that and it is allowing some backflow. This is generally happening because perhaps a valve doesn't close all the way, something is restricting it, and rather than closing all of the way, it only goes part way. That could be a cause of incompetency. There's also sometimes a valve can have too much pressure applied to it and it sort of blows out backwards. That happens sometimes too. But in either case, it's incompetent because it's allowing backflow. Then there's the opposite of that, which is stenosis. Stenosis means like a tightening or a narrowing. And in this case, we're talking about a valve with stiffened valve flaps. So rather than failing to close all the way like we saw here, a stenotic valve is failing to open all the way. So when the force comes in behind it, rather than opening up nice and wide, it might only get open part way. This is, of course, limiting the amount of blood that can make it out, and it's also a lot more work for the heart to pump blood. We have a lot of different options for repairing or replacing valves that have failed. They've got mechanical valves, so these are just made of synthetic materials that can be placed there in the heart. You can also receive donated heart valves from animals, or this is even a donated organ that you can receive from an organ donor. You don't need the whole heart, you can just get the valves. Although it's my understanding that in those cases, they do go with the animal valves a lot because, of course, if you take a heart out of a cadaver, if you take a valve out of a cadaver heart, the rest of the heart is now no longer helpful to someone else, right? Anybody know what type of animal they often use?
Pig.
Yeah, pig hearts are often used. Their anatomy, especially in the heart, is very similar to ours, and so their valves can be very useful. Let's see, we'll talk about blood flow through the heart in lab, so we're skipping past this. In order to make sure that everything stays balanced and everything stays equal, there has to be the same amount of blood passing through the pulmonary circuit as there is passing through the systemic circuit at any given time, right? And yet, as we saw, the pulmonary circuit is a lot smaller in terms of the distance that it covers. And so we have a lot of large, low-pressure vessels in the pulmonary circuit. You don't need as much pressure because they don't have to be pumped as far, okay? And this also allows us to send more blood through to keep the volumes equal to that in the systemic circuit. By comparison, the systemic circuit is much longer, as we saw. It says they're high friction. Now, when they say high friction, they don't mean that somehow the inside of the vessels are roughened, or not in that way. Okay? It's high friction because it's so much longer. There's such a greater distance to travel that there's a greater cumulative amount of resistance facing the systemic circuit. In terms of the actual blood vessels, it's the same, but we've got Again, a higher cumulative amount because of the greater distance. So that high friction circulation, as they're calling it, that greater amount of resistance results in another major difference between systemic and pulmonary, which is that the systemic circuit has a much higher pressure within it. Okay. We'll look later on in lab next time, on Thursday, talking about blood pressure. And the readings that we come up with are all from the systemic circulation. If you were able to do that in the pulmonary circulation, you would find the numbers much lower as a result. We mentioned this a little bit earlier already, that because of this, because of the extra workload on the left ventricle, its muscular wall is approximately 3 times thicker than that in the right ventricle. Here we're seeing how that looks a little bit. The organization of the two ventricles is almost like the left ventricle is its own thing, sort of fully built, and the right ventricle is almost like an addition. That is how it looks. And notice the layer of muscle here in the left ventricle as compared to the right. And again, that's because of the greater force it takes to pump blood through the systemic circuit. There's a subdivision. Sometimes people will talk about the coronary circuit as being its own independent circulation. I think of it as a subdivision of the systemic circuit for a couple different reasons. Okay, but the coronary circulation is the division of the circulation that supplies blood to the heart muscle itself, as you're seeing there. Now, I hadn't really thought about this before, but a student asked me a couple years ago, and I thought, well, I'll bet she's not the only one with this question. Why does the heart need blood vessels in it? Why does it need this coronary circulation when there's blood going through it? I said, what do you mean? So we'll go flowing through the chambers and everything. There's already blood going through. Why do you need these vessels? Well, the reason why, what she was asking is, couldn't you just diffuse oxygen into the heart muscle from the blood going through the chambers? And the answer is only a little bit, right? That diffusion will only work on a scale of maybe a few cells, right? Anything farther in than that, and it's just too great a distance, too slow of a process to be effective at all, okay? So the heart muscle needs its own perforating blood supply, little arteries and capillaries that go into the muscle and feed it that way. It says here that the blood in the coronary circuit is delivered when the heart is relaxed. So blood through most of the systemic circuit is being delivered because of the pumping action of the heart, right? It's squeezing all of the blood through these vessels. But in the coronary circulation, the majority of flow happens during relaxation of the heart. There's a couple reasons for that. Can you think of any reason why blood flow or delivery in the coronary circulation would happen during relaxation rather than contraction?
Well, the contraction constricts this.
Right. So as we know, when muscle contracts, it swells up, right? And it applies pressure. So when the heart muscle contracts, it is temporarily clamping down on the little vessels that flow through it. Not promoting blood flow, but restricting it. And the other reason why is because of how the coronary circulation is set up. Let me see if they have a picture, if I need to draw one. You can kind of see it in here. There are two major arteries of the coronary circulation. They just call them the left coronary artery and the right coronary artery. And if you can see here, they are both branches off of the base of the aorta. And they're actually low enough down that they're near the attachment of the aortic valve flap. So if you were to look inside the aorta, remember we talked about the aortic semilunar valve? It would be in here like this, with the coronary arteries being near the attachment of those valve flaps. So when the left ventricle contracts and forces blood out, okay, it's moving in this direction, not really turning around and going back into the coronary arteries very well. Also, like we said, the contraction of the heart muscle is kind of clamping down on those things. But when contraction of the ventricle is over and this valve closes again, is there still pressure inside the artery? Well, let me ask you this. If you've had your blood pressure taken before, or maybe you've never done that, blood pressure is expressed as two numbers, right? What's the average blood pressure? 120/80. The 120 is the force you find in the artery when the heart is contracting. The bottom number, the 80, is the remaining force that exists while the heart is relaxed. So to use that to answer our question, yes, there is still a fairly significant amount of pressure in the artery even when contraction is over. And that residual back pressure will then force blood into the coronary arteries to feed the coronary circulation. That, combined with the fact that the heart muscle is now relaxing and there's no more pressure on these vessels, can promote flow through them. Do you guys understand how that works? Kind of. Let me talk about this. There's a phenomenon that exists called the Windkessel effect. Have you guys ever seen those little videos they have of like blood flowing through a little capillary or a little arterial? It's like microscopic. It's like a microscopic video. You can see the little cells flowing through. You guys ever seen anything like that? Maybe we can get a YouTube video of it. Alright, so we're seeing in here, it's not colorized, but these are all little blood vessels flowing through capillaries and small arterioles. I want you to notice their movement. We'll just watch it for a second. See how it appears pretty steady and consistent in terms of its speed and movement? And yet, the heart, which is driving this movement, is not pushing everything steady and consistent, right? It's going in gushes. Boom, boom. So how is it that we have consistent, steady blood flow through small vessels when the heart is pumping in gushes? Well, that's what we're addressing here. And again, I hope you're okay with impressionistic art because, like I said, I don't art good. So this will be our heart here. And of course, coming up out of the left ventricle is the aorta. It goes through and does a big loop like this. That's going to be the artery that feeds the systemic circuit. One thing about these large arteries is that they are elastic. That means they stretch, right? Flex or stretch. So that when the left ventricle pushes blood into the aorta with great force, what does the aorta do? It expands, exactly. So during contraction, the aorta will actually expand with the force of blood being pumped into it, like blowing up a balloon. Okay? That's again because of the greater pressure. So the blood is being forced in there, and yes, it's being driven along by the pumping action of the heart, but it's also expanding those blood vessels. And you can feel this, right? If you've ever done a pulse on your neck before, you feel the artery hit your fingers because it's temporarily expanding is that force is going through there. Okay? But eventually, I mean, that contraction only lasts so long. The force of the heart contraction will stop. And the aortic valve will close. Like a balloon, when you stop applying the pressure that blows it up, what does it do? Yeah, it recoils back down. And have you ever done that before? Have you ever taken an inflated balloon and sort of like taking your fingers off of it? It recoils back down, and what does it do? Flies around the room, right? Because it's shooting the air out through the compressive force of its recoil. Well, the same thing happens here. As these large arteries recoil back down, they are pushing blood through. It can only go one way. This valve is closed, so it can't go back into the heart. Where does it have to go?
Forward.
It has to keep going forward. So when you look at something like that video of blood flow through a capillary, like why is it consistent? Well, because part of the time it's being pushed by the heart's pumping, and part of the time it's being pushed by the arteries shrinking back down. Okay? And if we go back to what we were talking about before with the coronary arteries, that contraction of the large arteries is going to push blood forward as well as into the coronary circuit. Okay? It's just not back into the heart because the valve is closed. Does that make a little bit more sense now? Okay. Some anatomy that we'll cover more in lab. All right, so when talking about the coronary circuit, that feeds the heart. When we get to disorders, we get to ones like this: angina pectoris and myocardial infarction. They're both interruptions in blood delivery to the heart muscle. The only difference is this is temporary or incomplete, and this is permanent. Okay? Angina pectoris. Does anyone know what that means? It literally means chest pain. Okay? Sometimes they just use the first word, and I don't know why this is, but you heard me pronounce it angina pectoris, and a lot of times if they drop the pectoris, they say angina. So I don't know why it gets a different pronunciation when you lose one word, but that's how I've heard it said. And that's exactly what it sounds like. It's characterized by one of the same things that we think of as a sign of a heart attack, the chest pain. And it's really being caused by the same problem, which is a deficiency in blood flow to the heart muscle. This could be from the same thing that causes a heart attack, like for example, a little blood clot, but maybe rather than persisting, it dissolves, blood flow is restored. Or maybe there is some like atherosclerosis. Do you guys know what that is? They talk about plaque building up in arteries. So if you look at a cross-section of an artery like this, and again, think of this as a coronary artery feeding your heart muscle. There's the muscular layer of the artery. And here's the inner endothelium. Now this would be a healthy artery. But as we know, sometimes through poor diet and other, generally lifestyle kinds of things, you can get little bits of garbage building up under that inner lining there, right? They call it plaque, atherosclerotic plaque. So rather than being nice and smooth and circular like that, these deposits build up. Underneath the endothelium, like so. Now this is a fairly small one, so it's not really significant. But does that somewhat narrow the diameter of this blood vessel? Yeah. And that would therefore decrease the amount of blood that can flow through it too, right? Sure, because then the diameter is narrower. What happens then if our disease of atherosclerosis continues progressing and that buildup gets more and more? Now, would you say we have a pretty significant narrowing of the diameter of the blood vessel? Yeah, sure. And therefore, a fairly significant decrease in the amount of blood flow too, right? So what happens if you're working hard, exercising or something like that? Your heart is beating faster, the muscle's working harder, so it needs more blood flow too. Is it possible that the heart can start demanding more blood than this narrowed artery can deliver?
Sure.
Yeah. And then the heart muscle does what other muscles do when they're overworked and fatigued. It hurts, feels sore, and decreases in efficiency. And that's what you're feeling in angina pectoris. It doesn't necessarily have to be completely occluded. You could just have a situation where the demand is greater than the supply. It causes the heart pain that you feel as angina pectoris, but what do you do then? You rest, you take a load off, and eventually the heart muscle can recover. Well, what if the deficiency is severe enough or long-lasting enough? Can that heart muscle actually die, the cells die? Yes. And that's what's called a myocardial infarction. That's the medical term. You know it as a heart attack. What happens is, again, the heart muscle is not getting adequate delivery of blood, and the cells starve or they suffocate, I guess is a better term, and they die. So it could be from a sort of more advanced case of this. I've heard of certain people having coronary arteries as much as 90% occluded. All that garbage, eating steak and eggs for breakfast every day of your life, builds up underneath, and now you have an artery that barely any blood gets through. If this is your coronary artery, and you're just sitting there in your chair right now during class, are you noticing any problems? No, probably not. Your heart's not working very hard. But if you start to do something demanding, is it greatly at risk? Yes, because it is so narrowed that if you exert yourself and the heart is working hard, it's going to have a very limited blood delivery. And it could get so fatigued it can't recover and it actually dies. Or, as is sometimes the case, for myocardial infarction, we could see a clot. So we talked about thromboembolic disorders last time, right? You remember what an embolism is? A blood clot that breaks free and lodges itself in some vessel. So suppose that happens and a blood clot comes along and jams itself in this artery. Nothing further downstream is getting blood flow, right? And if that stays for a few minutes, the heart muscle can die. Can you die of a heart attack? Yes. Can you have a heart attack and not die? Yes. So what's the difference between a survivable heart attack and one that kills you?
Is it severity or how long it's blocked? Or?
How long it's blocked has more to do with whether or not the muscle cells will die. Whether or not you die has more to do with the extent. See what I mean? How much muscle tissue is affected. Let's go back to this picture here. If that happens in this blood vessel, there's our clot. Nothing downstream is getting oxygen delivery, right? And that might affect, say, this area. Is that bad? Well, of course it's bad. Some of your heart muscle is dying. Is it fatal? Probably not. What happens if that occurs, like, say, here? Now an entire half of your heart is not getting any blood flow and is potentially dying. Are you likely to survive something like that? No, because half your heart dead is not really a survivable occurrence, right? So when we're talking about whether or not myocardial infarctions are fatal, it has a lot to do with the area of heart muscle that's been affected.
So how do they confirm a heart attack then?
Well, there are several signs that you can see that confirm, yes, this person has had a heart attack. There are blood tests and there are also changes on ECG. So we'll talk about ECG later. There's something called the elevated ST segment that we can look at, which probably means nothing to you right now, but we'll take a look at what that means. Blood tests include things like troponin levels and creatinine levels, which are both enzymes that can be released into the blood when heart muscle dies. But you can definitively confirm a heart attack through various diagnostic testing.
Now, what is heart disease then? Is it-
Heart disease is a general term that doesn't mean any one thing in particular. So you could call this heart disease, for example, because it is a disorder affecting or potentially affecting the function of your heart, atherosclerosis, especially if it's in the coronary arteries. And it could include any number of things. It's just a general term that means that, yeah.
So what about the body's ability to repair muscle? How does that
What do we know about our body's ability to repair muscle?
It takes a long, long time. You can't?
You can't. It's like nerve tissue.
Oh.
When it dies, it stays dead.
Okay.
And you can see here, replaced by areas of scar tissue. And so this is why when you have a heart attack, you have a permanent deficiency. Now again, if it's a small one, you can sort of get over that and come basically back to normal function, but you remain with areas of dead heart muscle forever because it doesn't heal itself in the way that, say, skin does.
But the living muscle can't compensate at all?
It compensates functionally. So again, it depends on the amount of area that's been affected. If it's a small one affecting a small area, and afterwards you do your cardiovascular rehab and maybe work on your fitness, the performance of your heart can be fine. But in terms of the actual cells and the tissue, it doesn't grow back. You see what I mean? But it would be kind of like, you could think of this like any other muscle, right? If you damage, say, the biceps brachii muscle here, if the whole thing is dead, you're going to have a lot of problems working your arm correctly for the rest of your life. But if, say, a small chunk of it dies, the other areas will grow in size and strength to compensate, and functionally, you'll probably be fine. Similar kind of thing in the heart. Looks like it's about time to reset this. 59 seconds.